Okay, mania subtypes, classic mania. Now, here we're looking at uh, uh, teenage or adult onset. Okay, we're going to see it's very different with kids. Uh, Currently, classic mania is euphoric mania, with grandiosity and that kind of stuff. Mixed or dysphoric mania, everybody here knows about what that is. Now, what's interesting is that if you go back and look at hospital records, and these are available back to the beginning of the 20th century, so we're looking at people coming into psychiatric hospitals. The rates of dysphoric or mixed mania have about doubled since 1960, and the rates of rapid cycling have about doubled since 1960. But for the first 60 years of the 20th century, it was very stable, year after year after year. Also, for many years, the average age of onset for severe manic depressive illness was 30, and now it's down to about 18. And it's gotten lower and lower since 1960. So one of the questions is, well, what's going on here? There's this extraordinary stability, and then we're seeing more severe dysphoric manias. Obviously you can have much higher suicide rates with dysphoric manias, a lot more suffering, more rapid cycling, earlier onset. And there's two things that have happened since 1960. One is increasing use of methamphetamine and cocaine as substances of abuse, and secondly is introduction of antidepressant medications. So the speculation, everybody here has been taught to, repeat this mantra: correlation does not mean causation, right? Okay, but sometimes maybe it does. Okay, so anyway, the assumption is it may be that this antidepressant exposure actually, in the long run, may contribute not only to more manias, cycloacceleration, but increasing rates of dysphoric mania and of rapid cycling. Okay. Now, rapid cycling, by definition, is 4 episodes per year or more per year. Ultra-rapid cycling is 4 per month, and then for a while they called it ultra rapid cycling. And it's like, how many ultras can you add on there? It's sometimes now called ultradian. It's every day or two flipping back and forth, between mania and depression. I'm going to tell you the absolute worst case of rapid cycling I ever saw was in a psychiatrist. And I felt so horrible for this guy. This man was probably 40 years old. He started off with a more typical presentation of manias and depressions, but got into severe rapid cycling, and every 2 or 3 days he would flip from mania into severe depressions, and back and forth and back and forth. And he, honest to God, he just came for like a 10th opinion or something. I didn't have anything else to offer him. He had all of the standard, appropriate, aggressive treatment, and it was out of control. And he said, I know this is because early in my illness, I was exposed to a lot of antidepressants. But what he said to me, I'll never forget this. I only saw this man once, and my guess is I bet he ultimately killed himself. I just don't know. But what he told me, he said, when I saw him, he was depressed. He said, honest to God, John, right now you're seeing me and I'm depressed. I swear to you, I can walk out of here and 3 hours later I can flip into a manic episode. And he says, people talk about this concept of sense of self. You got rapid cycling, you can flush that down the toilet. Okay? And the only job he was able to get was working at a prison. And they cut him a lot of slack because there were just days he couldn't function. This can go from bad to worse. Now, fortunately, most people that have rapid cycling don't have this chronic course, okay? This is the biggest study on rapid cycling, 2002, and you can see 900 some patients followed for 7 years, and the second bullet item here, 19% of people had periods of rapid cycling, and this is also about the rate that has been shown in other studies, okay? So I'm not talking about, keep in mind, I'm not talking about kids, but adolescents and adults. About 1 out of 5 will have rapid cycling at least at some point during their illness. Now, of these, the 19%, okay, of these, only 18% did the rapid cycling last for more than 2 years. The majority of people with rapid cycling, it's not a continuous or permanent condition like it was with this man I just talked about a few minutes ago. It tends to be, I think the best way to look at it is a worsening, a revving up or intensification of bipolar disorder that does not tend to be continuous, although 2% of those that had rapid cycling, it was continuous. Now, what is it that may contribute to rapid cycling? Not much you can do about this, but it tends to occur more in people who were symptomatic for a longer period of time before they really got on appropriate medication. Okay, so that's after the fact, but that's a factor associated with the history of child abuse, thyroid disease, sometimes, but substance abuse is the number one. And here, I really should make a different slide that says substance use or abuse, and it's mainly stimulants or antidepressants. Okay, so the thing to do is to get in and try to eliminate whatever the problem is first. And then we'll talk about medication treatment for rapid cycling a little bit later.